Tell us just a little bit about your background and what you do.
Sure. My name is Matt Griffith. I'm a assistant professor at the University of Colorado Anschutz Medical Campus and a staff physician at the Rocky Mountain Regional VA, where I do pulmonary and critical care medicine. And I'm also the co-director of diversity, equity, and inclusion for the pulmonary division at the University of Colorado.
Great. That background is particularly suited for what we're going to talk about today, which relates to diversity and inclusion. I had two topics in mind. The first is, things that these are two things I've heard of as a generalist, but one is about pulse oximetry. What should clinicians know about the accuracy of pulse oximetry in dark-skinned people?
That's a great question. And this issue has been in the news a lot during the current pandemic. But I think that first we have to kind of be specific about what we're talking about, because there's a widely used scale called the Fitzpatrick scale created by dermatologists that characterizes skin pigmentation. And so some of the studies that have been published recently are specifically looking at dark skin tones and the accuracy of pulse oximetry. And there are other studies that have used self-identified race and the function of pulse oximetry. And so I think those are important things to tease apart. So it's important to know that this is not necessarily a hot topic that's just now in the news. There have been papers published during the entire kind of lifespan of pulse oximetry in the 80s and 90s, describing, differences in function between people of different skin tones. Mostly as new technologies came on the market, they'd be sort of tested in a variety of population, and this would be published, but it never really gained traction until the current pandemic. So in terms of patients with dark skin tone, there was a pretty good study in 2005 in the Journal of Anesthesiology where Bickler et al. Found that using the Fitzpatrick scale of skin tone that and measured exhaled breath mass spectrometry, they found that commercially available sensors used in the anesthesia field overestimated oxygen saturation in dark-skinned individuals. And another study more recently published last year in the BMJ Open Respiratory Research found that in the ICU, again, different than an anesthesia population, they found the same findings, that most of the consumer marketed oximeters, at least 50%, overestimated oxygen saturation in patients with darker Fitzpatrick skin tones. And these papers have not had the impact at all of two more recent studies, which many of you may have heard of, which looked at patients' self-identified race and oximeter function. The sort of first paper was from University of Michigan, Mike Sioting, published in New England Journal December of 2020, which found that occult hypoxemia, there's an observational study that showed that occult hypoxemia occurred in about 15% of Black patients in ICUs and about 5% of white patients. And they determined occult hypoxemia to be an observation that a arterial blood gas value showed a low oxygen, while the recorded oximeter value showed a normal oxygen saturation. And they found there was no safe level of oximetry reading. There wasn't an oximetry reading of 95% or 96% in which no patients were hypoxic. Across all normal oximetry readings, they found some patients were hypoxic on blood gas. And so this, again, kind of furthered this message that patients who identify as Black are more likely to experience this occult hypoxemia. A more recent paper published last month in February by Henry et al. In Critical Care Medicine duplicated this finding, pointing out that this affected the disparity of occult hypoxemia was more prevalent among Black patients who identified as Black, and not present compared to whites among Asian or American Indian populations. But they also found that regardless of race, this occult hypoxemia led to increased mortality. And so, the takeaways are, first that, the takeaways are, one, that commercially available oximeters fail to indicate hypoxia in many groups of patients, but this disproportionately affects those with dark skin as well as those who identify as Black. And the second that's kind of more interesting is the two studies that I just mentioned were observational, which is to say that they used existing data sets. So these were patients who had blood gas values that were abnormal and had oximetry values. And yet this gap between those two measurements was associated with increased risk of death. And so it's unknown how many patients, never even had a blood gas checked because of this normal oximetry reading and may have experienced a bad outcome. So, I think that it's interesting to say that this phenomenon, even when identified by an abnormal ABG, increased the risk of death in these patients.
Yeah, that's great. A lot of information there. So it is. It does seem that this is not just a measurement thing divorced from clinical medicine. These have clinically meaningful effects.
Mm-hmm.
And when you said that the group with the occult hypoxemia had increased mortality, was that compared? What group were they being compared to?
So yeah, the group that had a occult hypoxemia, which is to say hypoxemic on ABG, not hypoxemic on saturation, was compared to a group that had observed hypoxemia, so where the two values were concordant. And again, adjusting for other risk of death, adjusting for kind of similar characteristics, the population with the occult hypoxemia had a higher odds of death.
Right. Okay. So it's actually the measurement or the missing information that was the imputed cause of the mortality.
As best as they could judge. Now there might be an unmeasured confounder in there that sort of increases your risk of occult hypoxemia, but that was their hypothesis.
Okay. So my next question was going to be what should clinicians do knowing this information?
That is a good question, and I think it depends on the setting. The papers I referenced a moment ago were mostly in the ICU or the OR setting, where it's not a challenge to get a blood gas. These were observational studies where they sort of required blood gases to do the study. And so, you could argue that the increased risk of death, seen in these studies was potentially because of fixation bias, right? That providers saw a normal oxygen saturation on the monitor, they got an abnormal blood gas and wrote it off as a spurious finding. Maybe it was a venous puncture. Maybe there was a med that they gave they thought might interfere with it. So a simple answer that directly addresses these papers is just to say, if you have a abnormal blood gas in a patient with a normal oxygen saturation on the monitor in an ICU or OR setting, you should probably believe the blood gas and act upon it rather than relying on the saturation, because again, that's the population that was identified in these studies. But more broadly, I think that oximeters are being used by patients, in their homes these days, and certainly during the pandemic, to kind of monitor themselves for warning signs of respiratory failure. And I think that, that's a good practice, and again, works in most patients. They accurately pick up hypoxia in most patients. There's just a higher risk of this spurious finding among patients with dark skin, but even among patients with dark skin, they still work, most of the time. But again, I think we have to just peel back some of our, certainty when using this tool, and, understand that we have to look at the whole clinical picture and rely on other tests. In the ICU, getting ABGs where appropriate, and when making important clinical decisions, rather than relying on the oximeter. And in the clinic, being aware that just because a patient has a normal oximeter reading, if they're showing signs of distress or there's a concern, being aware that this is a fallible tool and not as potentially infallible as we once assumed.
Mm-hmm. Yeah, I'm going to ask what might be a basic question, because I've been out of clinical medicine for a while, but I understand that people practice in the field I used to be in, rely a lot more on venous blood gases than arterial blood gases to look at PCO2 and pH. Is arterial blood gas sampling still pretty commonly done?
It kind of depends on the setting. I would say that venous blood gases are used often in ICU settings where, again, we're titrating, ventilators for PCO2, and a patient may not have an arterial line to facilitate easy draws. And potentially in the outpatient setting where a patient, could be more uncomfortable with an arterial draw. So, venous blood gases are used. And however, the correction factor is a little bit in question. There's sort of in some of our pulmonary algorithms, such as, for example, a lung allocation score, they have a fixed correction for a venous blood gas. You add on some number of points to convert it to an arterial blood gas value to sort of equilibrate it. But in clinical medicine, it's not quite as direct. So yes, they are used, but it's often, as you said, more for PCO2 and pH than for oxygen measurement.
Okay. Oh, that's really good information and good advice on on how to keep it in mind, what to do with it. I wonder if we could move on to the second general category of questions I had, and that concerns pulmonary function testing. Could you tell us anything about the controversy about whether to correct pulmonary function testing based on race or ethnicity?
Yeah. So, just to give some background, there are equations that are used to generate predicted values for lung function tests. That essentially creates a range of values that would be expected to be normal for a particular person, and then we collect the measurement, and then we compare it to these values to determine if the patient has disease or is otherwise healthy or normal. And these equations, for essentially as long as they have existed since the 1920s, have included some combination of gender, age, height, and race. And these the controversy is whether self-identified race is medically relevant, which is to say, are the bodies of people who identify as Black or Asian or white different from each other in medically important ways that, should inform diagnosis of disease and treatment decisions. And so, that essentially is the controversy.
And are there certain specific pulmonary function tests where this is a consideration?
Yeah, that's a good point. When we do pulmonary function testing, we usually do 3 different types of tests. There's spirometry, there's lung volume evaluation, and then there's diffusion of carbon monoxide. And at various points over the last 100 years and even in the last 20 years, all 3 have had some ethnic adjustment. But as of the most recent guidelines for all 3, only spirometry still includes a racial adjustment. And spirometry, just for background, is a test that measures lung capacity as well as kind of the volume of breath you can exhale quickly. And these are tests, and also the response to bronchodilators like albuterol. And these are tests that are used primarily to diagnose COPD and asthma and to monitor people for occupational lung injuries. And so those are the sort of common contexts these are used. And so mostly, again, just applies to these spirometry predicted values.
Yeah. Well, so you intimated about the question of whether so-called race adjustment is biologically plausible. So, big question, I suppose. Were these adjustments based on historically derived samples, and could those samples have been biased?
Yeah, I mean, that is essentially how we generate these equations, is using either prospective or existing data sets of non-smokers of various ages and using those to generate these predicted values. And, just for some historical context here, spirometers have been in use for, since the 18th century, Thomas Jefferson actually famously wrote a piece about spirometry, comparing whites and blacks in the 18th century. And from the very early days of these measurements, it was noted that people who identified as black in America had smaller lungs than people who identified as white. And that observation has never really been challenged until recently. That's always been, and so race has always been factored into these equations. And over every, generation of pulmonologists seems to generate a new version of these equations, and they more or less include the same values of age, race, height, and gender. The most recent addition is the Global Lung Initiative, or GLI, which published their equations in 2012. And GLI, for the previous generation was called the NHANES 3. And NHANES 3 was derived from a population of about 8,000 Americans. And they had pre-identified racial categories of white, black, and Mexican American. And so they generated predictive values for these equations. GLI sought to, get a multinational cohort to try and reduce some of that bias. And so they sort of gathered existing data sets of lung function from around the world. They didn't collect any prospectively. They just sort of gathered existing data sets. And, they mostly drew from America and Europe, where you might see the effects of kind of systemic racism and other factors that might affect lung function. But they also did include populations from China, Korea, Taiwan, Thailand, and Mexico. And so, however, they only included out of the 80,000 patients that were included in the GLI derivation cohort, only about 1,100 were from Africa. And those were primarily from Tunisia and Algeria, so kind of different populations than would be considered African American in the U.S. Only about 140 were from sub-Saharan Africa, and those are from South Africa. And it's not reported whether those were South African whites or what race they identified as. So again, most of the predicted values globally for people with dark skin who identify as black were drawn from America. And so, again, it's this idea of, are we truly measuring genetic characteristics or the effects of racial self-identification?
Well, yeah, thank you for that information. So it is still possible that we've got a pretty, significant bias in this based on the sample there. Has anybody looked at effects on, clinically important effects, say morbidity or mortality, whether racial or ethnic adjustments have any effects there, whether they affect patient outcomes?
Yeah. The answer is yes, people have looked at it, and then the answer of does it affect patient outcomes is probably no. And I'll highlight kind of two studies published last year that kind of looked directly at these questions. There was a paper in December of 2021 that looked at an existing cohort of patients that were followed longitudinally to look for atherosclerotic heart disease. It's called MESA. It's a cohort that's been used for a number of studies. And they found whether they used the racially adjusted value or whether they converted everybody to a category called other. So GLI, the lung function database study that I mentioned a moment ago, they ultimately produced recommendations for 5 races of people. One were whites, one were African Americans, one were Northeast Asian, one were Southeast Asians, and then everybody else who didn't fall into one of those categories was grouped into an other category. That was about 25,000 or 20,000 out of the 80,000, so about a quarter to a third of the whole population in GLI. They were either missing racial data or they belonged to races that didn't fall into those categories, and so they created an other equation. And so with the there's people on the doing analysis of MESA data did is they put everybody as either their assigned group per GLI or put everybody in the other group and looked at if there were any different, significantly different when they adjusted for lung function, if there were differences in the ability to predict COPD, basically events or mortality. And they found that essentially the racially adjusted values did not predict these events better than just these straight up and down other values, which is to say that, by racially adjusting people, it didn't really improve ability to prevent or detect disease. Another study published last year by Gaffney used in Lancet used the NHANES data, and what they were trying to do was quantify harm. So that's kind of an interesting approach versus do racial values help us predict things better? Okay, so probably not looking at this MESA data, but is there a harm in using these predicted values? Because essentially what happens is Black people are predicted to have smaller lung capacity for their age, height, and gender than a white person would be using these equations. So for the same measured value, since we use percent predicted a lot in our terms of evaluating disease, the percent predicted would be higher for a Black patient than for a white patient for the same measured lung function. And so essentially a white person would be marked as sick or diseased for a certain measurement, while a Black person would be marked as healthy. And so the authors in this paper looking at this historical NHANES data wanted to say, is that harmful? Is this reclassification of potentially diseased Black people as healthy leading to harm? And so what they did is they looked at percent predicted values, and they converted Black patients to the white value, percent predicted. And they found that the white value, when applied to Black patients, was more predictive of their mortality than the Black value, which is to say, if we characterize these patients as diseased, they behaved more like they were diseased. They behaved like white people with similarly low values than as healthier people looking at straight up percent predicted. And so they suggested that racial adjustment makes Black people appear healthier and have a lower risk of death than they actually do, which might delay care. And I don't know if you want to talk about it, but there are other clinical uses of these values that could affect that too.
Basically, you could say that what the pulse oximetry and the pulmonary function testing have in common is they don't identify occult disease in dark-skinned people, and with potential untoward clinical effects because of that.
Yeah, I think that's a fairly, there's a review article that was written in the New England Journal in 2020 looking at various race-adjusted tests. And I would say EGFR is another example, the estimated glomerular filtration rate, which I would say almost universally, these tests bias you in that direction of taking a potentially diseased patient who identifies as Black and moving them into a healthy group, making them appear healthy rather than correctly identifying illness, and therefore leading to delays in care. Just as GFR, did that, they took a low GFR, and for a Black patient, a low measured creatinine, and for a Black patient, it was considered a normal value, whereas a white patient, it was considered an abnormal value for the same measured creatinine. Again, the direction of this bias is pretty common across specialties.
Right. Very helpful to know. Could you just repeat those ethnic groups again? There are 4 or 5 groups, and then the
GLI. Yeah.
Yes.
Yeah, the ethnic groups in GLI, and again, it mostly is derived from where the data came from. There were huge data sets available from Asia. So there's white, there's African American. So this is not to say Black, because almost all people who identified as Black came from America. The other samples were not very diverse. So there's white, African American, Northeast Asian, Southeast Asian, and they provide you with a list of countries that qualifies as Northeast Asian and Southeast Asian, and then other. And what's sort of notable about that is, as I mentioned in NHANES, which was the prior generation of predictive equations, it was white, African American and Mexican American as a distinct group. Whereas with GLI, anyone who identifies as Hispanic, regardless of your genetic makeup, is placed in the white group for predicted values. So again, we're conflating ethnicity, which is like an ethnic group, a language group, with a genetic, characteristic of a body, like a biological concept of a body. So all, if you have dark skin but you identify as Hispanic primarily, we are told that to use the white values. So again, it's just there's the idea that self-identified race informs information about a person's genetics or their bodies is the major troubling concept that we're dealing with here.
Now, when it comes to pulse oximetry, there is evidence that missing the hypoxemia has deleterious clinical effects. We can predict that would happen if we're missing some occult, decrease in pulmonary function in dark-skinned or Black patients. But do we know whether there are actual clinical effects because of missing that?
Well, so I think it's important to think about, like, what do we use spirometry for? Like, what are the potential things we're missing? Now, the studies I mentioned a moment ago, they more or less said, do we correctly identify diseased lungs or not? But they didn't look at necessarily, is that how we use spirometry? Not necessarily. So is there like in terms of what we would do differently? I think that there's sort of four main domains where we use spirometry that are helpful to think of when thinking about harms or affecting outcomes. One is lung transplant. And so we use a % predicted value to prioritize people for lung transplant. And so again, for a patient who is ready for lung transplant, who identifies as Black, and another patient who's ready for lung transplant identifies as white, we know that just because of this % predicted, use of % predicted, the Black patient will have a lower priority score, all values being common. And so we know that this practice would lead to a delay in lung transplantation. We also know that another use of spirometry in a lot of settings is it's the easiest test to do. It can be done with a handheld device in many providers' offices. And so in some ways, it's used as a screening test for other lung diseases. So a doc will do a spirometry in their clinic office or in a nearby lab that doesn't have full lung function test capacity, just to see if the patient's lung function is abnormal or normal, and then refer them for further testing. And so we know that Black patients who are listed for lung transplant, when they are initially listed, their scores are higher, which is to say there was probably a delay in getting them to that lung transplant center compared to a white patient. They hit the door sicker than a white patient would. And some have argued that it's because of this, again, false normalization in the screening process, these screening lung function tests that, again, make a Black patient look normal, that delays kind of care. Once people are transplant listed, once they get their score assigned, the score essentially derives when you get your lung transplant and your lung transplant kind of survival. So, the disparity sort of ends there. And then the other major, this is one of the main locations of controversy in this move to rethink the way we adjust lung function tests, is in occupational lung disease. So there are many occupations like firefighter, coal miner. There are many occupations where lung function testing is mandated as part of occupational health and safety regulations. And it's the idea is that it protects the worker. If they notice that the worker's lung function is declining over time, and is going from normal to abnormal, then they're being affected by their job. And they need, either that workplace needs to improve their safety standard, or that worker may need to be compensated for their occupational lung injury. And again, we use % predicted spirometry there as well. And so, there's data that suggests in many industries, Black workers who, often just because of our society work in jobs that are, higher risk jobs for a lot of these exposures, that Black workers are, again, they are for the same measured value. A white worker would be marked as disabled or appropriate for compensation, while a Black worker would not be marked that way. The controversy there is that many people in the pulmonary field who do occupational medicine feel that there is a biologically plausible reason why Black patients have smaller lungs than white patients, and therefore the risk of eliminating this racial correction is telling healthy Black people that they are unhealthy and therefore unfit for their desired job. There was talk that firefighters would lose their jobs because they would be deemed as unhealthy or be forced into like a medical retirement or something like that. But again, the data suggests that in terms of outcomes like mortality, that these racial adjustments do not correctly identify disease. But again, and there's also a concern that we would increase insurance premiums for Black patients, health insurance premiums for Black patients who, as data shows, are generally of lower socioeconomic capacity to pay for insurance than white patients. And we'd be placing an undue burden, again, on healthy Black patients by telling them that they are diseased when they are not. So these are the kind of proposed balancing measures for these changes, and those are the kind of key populations people are talking about.
Right. So you mentioned discrimination. Discrimination as far as transplantation, the issues about disability that's job related. One might also wonder whether they are being undertreated for asthma and COPD. Is that a consideration also?
Well, that's a good question, and the answer is probably yes. However, both GINA, which is the global kind of asthma society, and GOLD, which is the global kind of COPD society, that regularly put out fairly consensus recommendations for the treatment of these diseases globally, have moved away from using spirometry to guide treatment decisions and more towards clinical syndrome characteristics, dyspnea scores, exacerbation frequency, rescue inhaler use. And so the racial adjustments wouldn't actually affect the diagnoses, because COPD is a ratio cutoff, though. Well, I actually have to correct that, because as of last week, there's been some movement in this field to change these recommendations, actually. So we used to have a fixed cutoff for the ratio of FEV1, which is the amount of air you blow out in the first second, and FVC, which is kind of the amount of air you can blow out in about 6 seconds. And if you were able to blow out more than 70% of your air in the first second, you didn't have COPD. Like you had to be 70% or lower to qualify as having COPD. As of last week, or the last 2 weeks, the American Thoracic Society and European Respiratory Society have recommended switch from a fixed cutoff to a lower limit of normal cutoff for this ratio. And that lower limit of normal, using current guidelines, would include race. And so, again, it could affect your ability to diagnose COPD. Asthma is mostly a clinical diagnosis at this point, so isn't really affected. And then in terms of pharmacotherapy, that's essentially driven by the clinical picture. But yeah, it's possible that as guidelines are changing, it may affect our ability to diagnose COPD and potentially could, again, underdiagnose it.
Okay. Great. That, I think, completes the number of questions that I was prepared to answer.
Can I just one other comment? Sure. Just about this controversy, because it's something you touched on, but we didn't really talk about, and I think it's important because it's like a widely held belief in the pulmonary field that there is a genetic component to this observation, right? We've observed that in America, mostly, Black people have smaller lungs for their body size than white people. And there have been studies that have tried to characterize the genetics of patients with African sort of genetic epitopes, and say, patients that have more African DNA have smaller lungs for their body size. And I think that, so that's a refrain we hear often when you have this discussion, that, listen, every time we've looked, we've found this, and there's a genetic basis for it. But what it ignores is that we have found countless exposures that people are exposed to during their lifetime that lead to lower lung function. And almost all of these are more prevalent in Black people in America specifically than white people. Low birth weight, poor childhood nutrition, increased exposure to secondhand smoke, increased exposure to PM 2.5, like small particulate pollution. All of these things are far more common in Black people in America than white people, and are all associated with lower lung function independent of race in adults. And so the major study in the New England Journal came out about 10 years ago looking at African ancestry and lung function, which found this genetic link and has been cited over and over and over again in our field. They acknowledged in their limitations that they weren't able to measure any of these social factors. So is race just standing in for kind of deprivation and lack of access to these beneficial resources and increased exposure to these harmful ones? Are we just measuring these societal effects when and then lumping it into race? And what's interesting too is in America, if you look at genetic homogeneity of racial populations, it varies substantially from one race to another. And in America, there's a couple good studies which show pretty much once you get about 30 to 25 to 35% African ancestry in America, you're most likely going to identify as African American. So the range of African genetics, ranges from about 30% to 100% in these populations. And so claiming that we can apply one formula to this group based on genetics, and yet knowing that the genetic makeup of this group is tremendously variable, is again problematic. And so I just think that is in terms of what is the resistance to change, it is the fact that, again, this is an observation that we've made over and over and over again since the 18th century. What are we actually measuring? Is it genetics? Is it societal factors? And, again, broadly, how much do we think that racial self-identification should lead to treatments we apply to your body, to your biology?
Yes. And there's an increasing recognition of how important the social determinants of health are in health outcomes.
Yeah, and just as a small comment too, with the EGFR thing that I didn't mention is, the National Kidney Foundation and American Society of Nephrology recently have requested hospitals and health systems to remove that racial adjustment from the EGFR equation. And so this is not unprecedented in medicine to peel back some of these racial adjustments. And, we can, look to our nephrology colleagues for, sort of guidance on this topic.
Mm-hmm. It's been pretty well publicized too. Yeah.
Right.
Okay, that's all I really wanted to ask. Is there anything else you'd like to let clinicians know as parting words or anything before we finish here?
The only, just as we kind of discussed with the pulse oximetry, like, what do you do now, right? Like you asked me, like, what should a clinician do when they're looking at a pulse oximeter? I think the idea of what to do as a clinician when you're presented with a racially adjusted PFT value, let's say your patient's kind of on the borderline, right? So there's a couple strategies, and one of them has been adopted by, I would say, there have been some leading voices in this field that have made one of the recommendations, and there's some people who have made another. One is like they did in the study I referenced, where everybody was converted to the other category, which is, again, a more racially homogenous group. There are some members of the American Thoracic Society who published a piece in Chest over the summer who recommended, look at the other value and then, treatment decision based on that, if it would change. versus, and they recommended potentially while we're looking for equations that don't use race and trying to generate those, use the other category as a stopgap. And then, as in the Lancet paper I referenced, where everybody was sort of converted to the white value, that's another strategy people have recommended. And potentially just either, rather than just blanket across the board, remove it, you could potentially publish both values side by side, the racially adjusted value and then an unadjusted value. And if your patient would be diseased in one value and not diseased in another, again, just like in the pulse oximetry, use that tool to kind of guide your clinical judgment rather than to be the be all end all for your clinical decision. Those are my recommendations.
Right. Always a good idea to use some clinical judgment there. Well, thank you very much. These were wonderful answers. I'm really glad you could join us today.
Yeah, thank you for the opportunity. You're welcome.
Okay.
So just to follow up, Dr. Griffith, what will happen next is I'll go through the transcript and clean it up a little bit, and I'll send it to Dr. Kaplan. He'll look at it as well. And when we are confident that we've got everything together and accurate, we will send it to you for your review and approval, and then I'll facilitate getting it published on our site and release it to our social media team.
Great. Thank you.
Thank you. And I think so one other question I forgot to ask you. Do you perchance have a professional headshot that you would be willing to allow us to use along with this editorial?
I can send you one.
Great. Thank you so much. I appreciate that.
All right. Well, thank you.
Yeah, thank you too.
Thanks so much.
All right. Bye.
Bye-bye.